Hello, in this video we will start discussing oral medications used in type 2 diabetes. These medications are divided into two main groups, insulin secretagogues and insulin sensitizers. Insulin secretagogues such as sulfonylureas and meglitinides, and we have insulin sensitizers such as metformin and thiazolidinediones. Sulfonylureas and meglitinides are insulin secretagogues. They work by stimulating insulin release from pancreatic beta cells. So their mechanism involves closing ATP-sensitive potassium channels in the beta cell membrane. This leads to cell depolarization, which opens calcium channels. The influx of calcium triggers the release of insulin from intracellular vesicles. So overall, they increase insulin secretion directly from the pancreas. This mechanism is glucose independent, which explains the risk of hypoglycemia. Sulfonylureas belong to the class of insulin secretagogues. They act by stimulating pancreatic beta cells to increase insulin secretion. For sulfonylureas to work, there must be functioning beta cells, at least around 10 to 15%. That's why their effectiveness decreases in the advanced stages of type 2 diabetes. Sulfonylureas are divided into three generations. We have first one and second one and third one, which is the most advanced and less side effects, I guess. Yes, and they mainly differ in potency, duration of action, and side effects profile. The most important side effect is hypoglycemia, which can sometimes be severe. Another common effect of sulfonylureas is weight gain. It is important not to use two sulfonylureas together, as this significantly increases the risk of hypoglycemia. So in conclusion, it can be said that sulfonylureas have different effects depending on the generation and the classification to which they correspond. Meglitinides are a class of insulin secretagogues. They stimulate insulin release from pancreatic beta cells through the same mechanism we discussed earlier, by closing potassium channels and opening calcium channels. The main drug in this group are ribaglinide and netaglinide. They are characterized by a rapid onset of action and a short duration, which makes them particularly useful for controlling postprandial blood glucose levels. They are usually taken before meals to control post-meal glucose spikes. And about insulin sensitizers, we have biguanides and thiazolidinediones. Metformin belongs to the biguanide class and is the only available medication in this class. It is considered the first-line treatment for type 2 diabetes. It mainly works by improving insulin sensitivity. Metformin works through three main mechanisms. It reduces glucose production in the liver, decreases glucose absorption from the intestine, and increases insulin insensitivity in peripheral tissues. This diagram illustrates the Cori cycle. So we have two different processes, glycolysis and the gluconeogenesis, in the muscle and in the liver. So in the muscle, glucose is converted into lactate during glycolysis. The lactate then travels through the blood to the liver. So in the liver, lactate is converted back into glucose through a process called gluconeogenesis, and the glucose returns to the bloodstream. Metformin acts at this step. It inhibits hepatic gluconeogenesis, meaning it prevents the liver from producing glucose. As a result, lactate may accumulate in the body, which explains the risk of lactic acidosis, especially in patients with impaired kidney function. So this mechanism explains one of the most important side effects of metformin, which is lactic acidosis. Metformin is contraindicated in patients with renal failure, liver disease, and heart failure due to increased risk of lactic acidosis. Metformin is the first-line treatment, as I said before, helps reduce weight, lowers triglyceride levels, and can be safely combined with most other antidiabetic medications, including sulfonylureas. Common side effects include gastrointestinal discomfort, such as diarrhea, which is why it should be taken with food. It can also reduce vitamin B12 absorption and may cause lactic acidosis. And now about thiazolidinediones. They are insulin sensitizers. The main drugs are bioglitazone and rosiglitazone. Troglitazone was withdrawn due to hepatotoxicity. About the mechanism of thiazolidinediones. They activate PPR gamma receptors, improving insulin sensitivity and reducing glucose production in the liver. So about the first step is, as I said, they bind to a receptor called PPR gamma, which is mainly found in adipose tissue, in the muscles, and in the liver. Once activated, this receptor changes the expression of insulin-responsive genes. This leads to increased glucose uptake into cells by increasing GLUT4 expression, and it also decreases the glucose production in the liver. So in addition, thiazolidinediones promote fat storage in subcutaneous tissue rather than visceral fat, which helps reduce insulin resistance. Unlike sulfonylureas, thiazolidinediones do not stimulate insulin release, so the risk of hypoglycemia is lower when they are used alone. The most important side effects are weight gain and fluid retention, which may lead to heart failure. They can also cause bone loss and liver toxicity. And also, in addition to using it in type 2 diabetes, they can also be used in PCOS to improve insulin resistance. And that's all for today's video. Thank you for watching.